Okay, so these models have mainly been focusing on process. And now here in part 3 of the CE, we're going to be getting into content-based models. So psychotherapy-based approaches to supervision. Now, in addition to the previous models focusing on process, now we're going to start talking about models focusing on content. Now, this informs your job as a supervisor in facilitating your supervisee's jump from theory to practice. This is where you're going to facilitate praxis. So this approach provides a framework to supervisees in which knowledge, theory, and technique derive from a specific orientation that informs the conduct of treatment and provides a clear focus for your supervision. This utilizes techniques from therapy as learning strategies. So, for example, in a psychodynamic approach, you're going to encourage a supervisee to pay attention to their dreams about their therapy clients. In cognitive behavioral, if you're doing cognitive behavioral type of supervision, you're going to give your supervisees homework. So this allows for you as a supervisor to assist your supervisee in developing specific competencies within treatment protocols. So this allows for your helping your supervisee to build a whole foundation of therapeutic skills. So let's take some popular approaches. Let's talk about supervision from a cognitive therapy perspective. In therapy, if you're going to do cognitive-based therapy, by definition, your therapy sessions are going to be structured, agendas are going to be collaboratively set, and the focus is on problem solving and on homework assignments. No different if you're doing supervision. Your supervision sessions are going to be structured, your agendas are going to be collaboratively set, your focus with your supervisee is problem solving, and you're going to give them homework because you're doing it from a cognitive perspective. So, first things first, you have some cognitively based competencies you are going to want your supervisee to accomplish. So number one, you have to help your supervisee develop appropriate empathy, caring, and regard for the patient and their situation. You want to help your supervisee achieve accurate problem formulation. That's crucial within cognitive-based stuff. And you want to help them do accurate case conceptualization. You want to individualize and customize the approach to fit the idiosyncratic needs. And once they get the basics down, then they have to learn the cognitive conceptualization for each of the DSM Axis 1 and Axis 2 disorders. Once they know that, then you have to help them to understand how to formulate treatment plans. So you see how the competencies follow directly from the theoretical orientation you're choosing within this supervisory context. So for example, in terms of formulating treatment plans, from a CBT perspective, depression, you're going to help your supervisee to focus on the negative self-evaluations of their client. For anxiety, you may want to help them to focus on the catastrophizing kinds of thoughts. You also need to incorporate comorbid conditions, customize a plan for this patient that works. Now, cognitively based therapy and supervision both emphasize developing the relationship and encourages a safe learning environment. They both require planning the session based on the problem formulation. How you want to help your supervisee to organize the clinical material they're getting in a cogent fashion that respects the cognitive orientation. This, of course, requires structuring both the supervisory session and your supervisee structuring the therapeutic session. So what you're going to want to do is set an initial agenda with your supervisee. You're going to want to make a bridge between sessions. You're going to establish continuity. So you're not going to start each session with how you're doing this week. No more than you would do that with a client that you're doing cognitively based work with. It's last week we're working on this. I gave you homework. How did you do with your homework? It allows for some collaborative agenda setting. What's important for the trainee? What would they like to work on? You're going to assign collaboratively agreed upon homework assignments. And you're going to help your supervisee to learn how to better respond to automatic thoughts or beliefs within the professional context. It's not therapy, it's supervision. You're going to focus on their thoughts and on their beliefs as a clinician, as a developing clinician. Now, there are also factors that are unique to cognitively based supervision. Number one, as a supervisor, if you're doing cognitively based supervision, you must listen to the entire tape. You cannot expect your trainee to adequately diagnose and report problems. By definition, they don't know what they don't know. That's why they're in supervision with you. So you must listen to the entire tape. When you analyze the tape, as a supervisor, here are some things you should be asking from a cognitive perspective. What do you believe is the client's most important problem? What do you think the supervisee thinks is the client's most important problem? What other data are necessary to accurately formulate an accurate case conceptualization? What do you believe your trainee did well? What do you believe were your trainee's weaknesses? What did they miss? What do they still need to learn? So that's from a cognitive perspective. You can see where different clinical competencies are going to come right out of that. If we switch over now to psychodynamically oriented supervision, this emphasizes the central importance of the supervisory relationship in structuring your trainee's subjective reality. Within this framework, the client, the therapist, and the supervisor are all viewed as co-creators of the clinical relationship and the supervisory relationship. So therefore, as a supervisor who's following this model, you want to explore the supervisory relationship as it relates to the clinical relationship. This is an essential task for supervision, and it allows for uncovering of neglected affective states. So you may want to say, for example, as a supervisor, you know, we've been doing supervision now for 4 or 5 months, and my experience is in the beginning, you were very excited, you were doing a lot of work. I found that I really enjoyed our sessions together, and I enjoyed how much work you were putting into it. Lately, I've been struck by the fact that you have much less energy. And in fact, I have a lot less energy about what's going on. So what's happening? What's changed? What went on? What's going on with you? What's happening? What's going on with me? Now, in both psychodynamic therapy and psychodynamic supervision, the helper in both situations is going to focus on transference and going to focus on resistances on the person being helped. They're going to pay particular attention to nonverbal messages. You're going to emphasize here and now experiences, what's happening between us. And countertransference exploration is going to be an important part of understanding fully what's occurring. Switching yet again, in family therapy type supervision, here supervision is going to focus on the trainee and supervisor as active agents and members of the system in which they are intervening. Active agents in the system in which they are intervening. This directs trainees to attend to process and how to design creative interventions to obtain structural change and upset the status quo. That's what you're trying to do in family therapy. So you're going to search for the unrecognized strengths and unused resources in both the family and in your supervisee. So you're going to use a perspective that multiple systems of influence are operating at all times on all three of the aspects of this, the family, supervisee, and yourself as a supervisor. And it's going to focus on the dynamics within and between the family system, the family therapist interaction, and the supervisee-supervisor dyad. So family therapy, on one level, focuses on assisting family members to achieve structurally based changes in behaviors and in internal emotional experiences by trying new ways of interacting that do not fit with the stories, the narratives that they hold about themselves. That's what we're referring to in terms of shaking up the status quo. So, since this is part of family therapy, your job as a supervisor who chooses to follow this model, you're going to work on multiple levels to ensure adequate treatment to the clients and perform parallel interventions with your supervisee. You're going to help them, you're going to encourage them to try out new behaviors so they can construct new and evolving narratives that reflect their growth as a clinician. You're going to help them shake up their status quo by trying brand new things that are going to change the stories that they're telling about themselves as developing therapists. So please direct any questions or comments that you have to my email, which is right here on the slide, and I thank you for your attention during the CE module.